Hi, I'm Dr. Jay Varma, and welcome to Thermometer. On this channel, I check the temperature of health in the United States and around the world and give you expert insights on infectious diseases and public health. Today, my guest is Dr. Tom Farley, a leader in public health practice for several decades, most notably as the health commissioner for the New York City Health Departments and the Philadelphia Health Departments. And of note, my former boss when I was working at the New York City Health Department. Thanks so much, Tom, for joining us today. So before we, jump into the discussion, I want to give everybody kind of an update on why I invited you here today. Both of us have, had our original training with CDC and have spent our careers in public health working around the United States. And what we're really concerned about right now is a lot of changes that are anticipated or have actually occurred at CDC. And I'm going to highlight a few of the big things that I've either heard from the news or heard from a lot of my sources inside. And then I want to turn it over to you, Tom, and tell me about what you've been hearing and what your concerns are. First of all, we've heard this week that CDC, that the president has nominated a new director for CDC. I have never worked with this person personally, but I do have some concerns about the fact that they have no substantive experience previously working at a state or local public health agency. And we knew from our previous director, Mandy Cohen, about really how critically important that is for a CDC leader. So I'm hopeful that this will be a good selection, but I'm also have some concerns. The second is we've seen the reporting that, multiple high-level people at CDC have resigned this week. From my friends and sources inside CDC, at least 4 of them had actually been planning on retiring anyway, but they moved up their timeline. And there's an expectation, at least among the people I've talked to, that a lot more senior leadership may be leaving pretty soon. The third is about what's called a reduction in force or cuts to CDC. The rumors that are coming out of several different people I know at CDC are that they may actually come this week, and that the most biggest cuts will be in global health, domestic HIV, injury prevention, and the toxic substances disease registry. And the final is news that's been reported about COVID funds that have been supplied to state and local health departments to actually bolster all aspects of infectious disease are being pulled back by this administration. So those are 4 big things that I've either read about in the news or heard about through my sources within CDC. Tom, what are the things you've been hearing and what are the things you're concerned about these days?
What I'm concerned about is that the attack on CDC is really very broad-based. It's not just infectious diseases, which what most people think about when they think about the CDC. And they're really attacks coming from 3 different directions. The first is this reduction in force, the RIF, so you've mentioned before, that may come out quite soon. This is part of a broader effort by Russell Vogt, who's the director of the Office of Management and Budget, and was one of the architects of Project 2025. And he has ordered all federal agencies, not just the CDC, to submit to him by March 14th, a couple of weeks ago, plans for shrinking their agencies, closing organizational units, and firing fairly substantial numbers of staff. What I've been told is that the RIF plan for CDC was submitted to OMB back in March, and had no input whatsoever from anybody at CDC. So no one at CDC even knows what's in there. But there's a lot of concern that it was done in ignorance, and it may have substantial cuts in it, perhaps as many as 30% of staff positions eliminated. So that's something we may be hearing about any day now, something we ought to be quite concerned about. Beyond that, though, on the longer term are also some very large issues. The second concern I have is in general budget cuts. If you go back to last summer, the budget plan put together by House Republicans was for it retained most of the CDC units, but it eliminated the National Center for Injury Prevention and Control, and it eliminated the Office of Smoking and Health. Now, why those units? Well, the Injury Prevention and Control unit deals with firearm injuries, and it deals with opioid overdoses. And so the gun industry doesn't like that, and the pharmaceutical companies that make opioids don't like that. And so this is really a political payback, I think, from those industries. And obviously, the Office of Smoking and Health is something that angers the big tobacco companies. So these are really politically targeted budget cuts. They were planned by the Republicans last summer. Now that budget isn't going to become reality. Now Congress is working under a continuing resolution, but the continuing resolution is such that there's a lot of flexibility by the executive branch to redirect funds. And so I think we may see the same sort of cuts take place just by executive order. The third thing I worry about is a formal restructuring of the CDC's responsibilities. There was a bill put in recently by 2 Republican senators that would transfer all functions that they called not communicable diseases over to the NIH, the National Institutes of Health. So everything from heart disease prevention, obesity, smoking, diabetes, injuries, HIV, which is in fact a communicable disease, other sexually transmitted diseases, all that would go over to the NIH. Now that's a terrible idea. NIH is an incredibly strong agency, but what they do is they research the causes and cures of illnesses. They have no experience running public health programs, and they have no mandate to run public health programs. So that would really greatly interfere with those prevention programs. So overall, these hacks are very broad. They're over the short term and over the long term. And I'm very concerned about what it's going to do for the health of Americans over the long term.
Yeah, so Tom, there's a number of issues in here that, we don't want to keep our discussion for too long, but I wanted to probe just a little bit more with you. The first is the fact that there wasn't any CDC involvement, as you said, any leadership involvement in developing this plan for a reduction in force. And that's what I've heard also from many colleagues I know, is that this plan was developed by people they don't know, and it may not even be people. It may have been AI, as far as I can tell. People just analyzing job descriptions and making decisions. Do you have any sense of how much like human input went into this, and if so, who those humans were, or is it completely opaque at this point?
No one has any idea. I would expect that it's going to be some combination of politically targeted cuts, again, those things that have angered certain industries, and then something done completely in ignorance, just looking at job descriptions or unit responsibilities and say, why should CDC be in the business of injury prevention in the first place? We ought to just stop that. The other aspect of the rift that worries me is that according to federal civil service rules, if a position is eliminated, that person then can move and take the position of someone else whose position wasn't eliminated if they have more seniority. And so that's called bumping. And so if you eliminate a lot of positions, it creates a lot of bumping. It ends up being like a big game of musical chairs, where everybody is doing a job that they're not really a specialist in. And that may work in a big factory where everybody's making widgets, but it doesn't work at CDC, where everyone is in a highly different and specialized unit.
Yeah, and some of these changes, they're so clearly, there doesn't really seem to be any clear public interest in mind. So if you think, for the example, about, the power base of the Republican Party is historically, or in recent times, has been in rural areas, right? Or places in the Midwest, places in the South, not the big urban centers. A lot of those rural areas, those small towns that they always talk about, are the ones that have been most heavily devastated by the opiate epidemic. I mean, that's where a lot of these, overdoses of misery have really occurred. And the second, of course, is the impact of tobacco. Now, I get the tobacco lobby and influence, but, during the past 15 years or so, seemed to be sort of a bipartisan anger at the sort of spread of opiates around the country and the devastation it caused. So it is really striking that, eliminating injury prevention would also eliminate opiate overdose monitoring and control, which one would have to believe is important to the voting base of a lot of the Trump administration.
What they really just want to do is get rid of the firearm prevention program, which is quite small. And the way to do that without drawing too much attention to it is just to eliminate the entire center. Or it could be that there's still some pharmaceutical companies out there making a lot of money on opioids. There's still fairly substantial sales. And CDC is one that's been pretty strong at saying that we ought to be reducing the prescription of these drugs.
Yeah. And we know very well, just to add on to your point before, that, moving public health programs into a medical setting or into medical specialty research type centers like NIH doesn't work. And the reason we know that, we as sort of the public health community, is this is the way it existed, in many places around the world historically. And one of the shocking things is, for example, when I was in China, one of the reasons I was based in China was because up until the SARS outbreak, a lot of the sort of Chinese public health surveillance programs and monitoring programs were embedded within what was called the Chinese Academy of Sciences. So the equivalent of their NIH. And one of the things they did was request help from the US government to remodel their public health system after the United States. So paradoxically and really badly, obviously, some of these changes are going to result in a lot of destruction to not only just the basic programs of public health, but the entire architecture of the way public health is designed, which makes it even harder to repair. Let's say there's a new administration 4 years from now.
assumes that the big advances in public health are going to come from more bench science. And yes, we need more bench science and a lot of good cures, but there are huge gaps between what we already know from bench science and the use of that across the country. You know, an awful lot of people out there have hypertension that can be easily treated by very inexpensive drugs that have been available for 30 years, but we need to have a program to get all those people on those antihypertensive drugs. That's what public health is about. And it's an entirely different function and different skill set for the people involved. It doesn't fit within NIH.
Yeah, and I think one of Tom, you've been obviously a leader for decades in moving the shift in public health a little bit away from its obsessive focus on infectious diseases towards the leading causes of death, most of which are due to either tobacco or metabolic disorders, diseases of lifestyle. But of course, we are facing the possibility of another pandemic. Bird flu has been a challenge and difficulty because one, because of the complexity. It involves animals in the wild, animals reared for food, animals kept at home, and it involves humans. But I think one of the biggest challenges is we just don't know when it's going to become a problem. These mutations are occurring. And what really worries me a lot is we saw so many missteps in COVID early on that were related to the fact that we didn't have a really strong, cohesive, all hands on deck approach. We had, leaders who seemed somewhat kind of like out of place about understanding how they needed to pull in people from across CDC as an agency, work closely with FDA, for example, on diagnostic tests. And then, of course, at those times, at least you still had the staffing of CDC, both at the federal level as well as the support to state and local health departments. But what I see happening now is you're putting in leadership that doesn't have experience in public health, has never, as far as I know, anybody who's being appointed to lead NIH, FDA, or CDC has ever responded or led an outbreak investigation. And then you're progressively hollowing out all of the expertise inside the agency from sort of the highest sort of executive levels down to the lowest levels. And then, of course, with all of these COVID funds being pulled. And just for people in the audience to understand, a lot of the money that was given for COVID was actually given for strengthening all aspects of infectious disease response. That was infrastructure that was used, for example, in New York City to make sure Mpox vaccines got to people quickly in 2022, because the same infrastructure you need to deliver a COVID vaccine is the same one you need to deliver the next flu vaccine or the next Mpox vaccine as well. And so I really worry that, if you think about public health in a way, the way we think about the military, when you destroy leadership, when you install too much political control, when you decimate the units and forces all at the lowest level, you're not prepared to win the next war.
Play that out a little bit, because I think everybody has heard that the federal government has stockpiles of bird flu vaccines, and they got antivirals out there, and that can protect us if bird flu starts spreading among humans. You and I have had a conversation separately about this, and I think you have concerns, and I have real concerns about how effective that can be, especially now.
Yeah, so let's start off and assume for the moment that what's in the stockpile will be effective. The flu antiviral, oseltamivir, also known as Tamiflu, that current PPE stocks will work. Let's assume for the moment that those are all going to be reasonably or have some level of effectiveness against an H5N1 outbreak. Even if that is the case, I have concerns from top to bottom. First of all, we know that, particularly looking at RFK's comments during the current measles outbreak, this administration is not going to be very eager to even release anything that's in the stockpile out the gate, at least for human health. RFK has said that his preferred approach to H5N1 is essentially to let it rip through poultry farms and hope that there'll be some immune poultry that'll somehow emerge, and now you'll have a new strain of birds that are no longer susceptible. That just basically shows a complete misunderstanding of the way birds are reared. We essentially rear birds for food essentially as one species. They pretty much all have identical immune systems. So that would never work. So let's assume for the moment that strategy, of course, also involves not developing a new vaccine, because we know that's part of the concern here too, is they're not really focused on a human health vaccine. So even if we have a stockpile, I worry that they won't necessarily release it because they're kind of hoping for natural immunity to emerge in birds and probably in humans. Second of all, I really worry that they're not going to do the incredible amount of upfront investment that's needed to get a human vaccine for H5N1 basically developed. And then, of course, even more importantly, how do you deliver it? Vaccines don't deliver themselves. Drugs don't get into people's mouths on their own. They actually require an enormous number of staff who, quite frankly, a lot of times are just sitting around making sure the stockpile is up to date and the inventory is collected and it's recorded. But those are people that are ripe for cuts from, the Doge team from Elon Musk, because on a day-to-day basis, you don't need them. When you need them is during emergencies. So I have a lot of concerns about whether the stockpile will be maintained, whether it include the latest and greatest vaccines that we're going to need, and even if they are used, whether this administration will release them. And then finally, even if they did decide to release them, whether or not there are the staff in place to actually make sure they get through that last mile.
I have concerns about whether, even if the state and local health departments have vaccine in hand, whether they can set up the vaccine clinics for people to come and get vaccinated. That takes an awful lot of staff, a lot of coordination. Even under COVID, it took about 6 months to get majority of the population vaccinated. And that was with the federal government being incredibly supportive and providing lots of resources. If you have an unsupportive federal government, it just would take a very, very long time to get people vaccinated.
Yeah. And I think, as you and I know very well, our public health agencies are progressively being stripped bare. Healthcare systems, a lot of people are like, well, why can't the hospitals just do this? They're now running with huge vacancy rates as well, too. People are exhausted from COVID. The jobs don't have the sort of prestige or reimbursement that people previously wanted before. And so I think we're really, I'm very pessimistic and very worried about what the future is, both for infectious diseases as well, of course, for the long term over chronic diseases. So Tom, before we leave our viewers today, instead of leaving them on this incredibly depressing note, what are some things that people you think actually should be doing out there to help protect public health?
First, there is a little hope here. When the initial Doge cut came through, part of it was eliminating positions of these new epidemic intelligence service officers. This is the elite epidemiology training program that both of us went through, and knowledgeable people screamed early, and those cuts were rescinded immediately. And so that this administration is sensitive to the right sorts of public pressure. So people need to complain. They need to complain to their elected officials. They need to complain to the press. They need to pass the information around. Say, you know what? If we lose the CDC infrastructure, that means more of us are going to die unnecessarily. And that's not really stating it too strongly. If enough of us say that quickly enough, we can have at least some impact.
Yeah, no, I agree with you completely, Tom. I think that there for such a long time, there's been a challenge because there hasn't been a strong public constituency for public health, right? It's very obvious to people when a hospital closes, right? Services that they expect to get on a day-to-day basis disappear. When prevention goes away, it seems invisible because the work of prevention often seems invisible. So it's really, really important if you're out there watching this video, share it with your friends and colleagues, make sure they know what's going on, and then use that voice on social media, putting calls to your local representatives. And that doesn't just include your senators and your House of Representatives people, your local health officials, your local city council people. They also have voices that can echo up higher. And the more that elected officials understand about how important you believe public health is, the more likely they are to protect it. And though we may not be able to stop all of these cuts that are coming, the least damage that happens is going to be protective for all of us in some way. So Tom, any other closing comments at all about this issue?
No, see, this is obviously we're in the fight for the long term. Immediately, it might be over infectious diseases, but this has to do with chronic diseases and injury as well. So people need to stay involved in supporting public health.
Great, Tom. Thank you so much for joining me today. And to all of you watching out there, if you enjoyed this discussion, please hit the like button. Please subscribe to this channel, Thermometer. All of those things make a huge difference. And, and as we've talked about during this session, getting the voice out about how important it is to save public health and to keep public health strong is important. And anything you can do to circulate this channel and circulate these messages is also doing that part as well, too. I'm Jay Varma. Well, thank you for joining us on Thermometer today, and look forward to seeing you on the next video.
Good day.